So first of all, before I start the video, I'd like to first of all congratulate Dr. Surya, because basically I think what he's done is so much of work in the system here, you know, overall done so much of work in not only, I think, teaching so many people, but also, educating everyone on the story here. And I think when you're trying to show complications of yours, I think it's a tricky game, because I think, as things stand, it takes time to show various complications of everyone in the world, what they are doing, things like that. So let's see now. I'll show you the case which I wanted to show you about. He asked me to show you a crazy case like dare to bear. So if you see this case here, pseudophakic bullous keratopathy is there with an anterior chamber IUL. Now, these are very complicated cases. The problem with these anterior chamber IULs are pretty bad. So you notice here what I'm doing here is I made my scleral flaps. My next step is I'm making a scleral tunnel incision. Now I'm taking off this hypertrophied epithelium there, and once I take it off, you see I can see a better view, and I'm seeing an anterior chamber IUL there. Now the flaps, one of the problems is they should be 180 degrees apart. You notice I did not have them 180 degrees apart. So at that stage, what I have done now is adjusted it so that I've got it exactly 180 degrees apart. I've gone in with a 22 gauge sclerotomy and then doing a vitrectomy. Now, in such cases which come to me from outside or somewhere, I do not know what is inside the eye. So I always go in and do a posterior vitrectomy, because the surgeon might have left a nucleus behind, an IUL behind, something might be inside. Once I've done that, make my scleral tunnel incision. Now the question is to remove the IUL. So you can see now I'm taking it out very slowly. The problem with these type of IULs are they get locked onto the iris, and it's very tough to remove. So you have to be careful. Invariably, sometimes they break. As you can see, it's broken here. But I've taken off one loop, then the second haptic. Now still some haptics are still inside. So now you can see the third one coming out. The fourth one is still stuck onto the iris through an iridectomy. Now you got to be careful that we don't produce a bleed. So I'm trying to remove it very slowly there, and you can see they're removed there. Once I've removed it, you can see slight bleeding is occurring, but it has been stopped. Now, once I have removed the anterior chamber IUL, my next step is to do the vitrectomy, which I've done just now, and then go in for a glued IUL. Now, you can see, since I already have a large incision, all I need to do is just extend. I can use it like a non-foldable IUL. Any IUL, 3-piece can be implanted, catch one haptic, externalize. Now watch the second one. Transfer the haptic from one hand to another. This is the handshake technique. You can see I've transferred it from one hand to the other. Once that's done, I go back in through the sclerotomy, catch that haptic, and externalize the second haptic. Now notice carefully, you'll see here the amount of haptic externalized is a lot. That is a very important issue which we need to understand totally. Then you take a 26 gauge needle, and you can see I'm created the Gabor-Charier's pocket and tucked it inside. Same thing I'm doing on the other side. Once I have both haptics tucked. So now what have I done? I've done the anterior chamber lens explantation. 2, I've done the vitrectomy. 3, I've done a glued IUL. But I have to do a pupilloplasty, though the pupil is small, because what will happen is if there is some closed angle, it will become open angle. So we do the single pass 4-throw pupillasty. For those who are watching, remember, take a 9-0 or 10-0 Prolene, go straight through the clear cornea and iris. Remember, you do not need a paracentesis on one side. On the other side, you have a paracentesis. Pass a 30 gauge needle through the paracentesis, through iris, railroad the two, bring the needle out. Now bring this loop out. This is the single pass. Now all you do is remember the number 4, pass it 4 times, and that is game, set, and match. Once you have done that, you can do as much as you want. So notice carefully now, from one side I'm going in. Remember, you do not need a paracentesis on both sides, only on one side. On this side you don't need. On this side you need. So now you have brought the needle out. Now you bring the loop out. You can see I'm using an endometer from outside to see better. Once that is out, now you pass it 4 times and you'll be done. Now, what does this help us in? 1, the air will remain in the anterior chamber. 2, a closed angle will become open angle. And 3, I have created a pinhole pupil. So any astigmatism problem gets solved automatically. So remember that even if you have a case like this, just do this pinhole pupillasty and the whole problem gets solved. Now we take the endothelium facing us, as you can see, inject a bubble. Now you see here the bubble there, that's a type 1 bubble. Now question comes, why am I doing a PDEC? Why I never do DSEX? Why do I never do DMEX? And in Agarwal Center, we do about 100 keratoplasties a month. So the reason is simple. Remember, in DSEC, you're taking about 80 micron, 100 micron, whatever it is, but it is too thick, which is not needed. In DMEC, you're taking 15 micron, which is fantastic. But there is one problem in DMEC. The biggest problem in DMEC is you cannot take off the endothelium and desmase till the donor is 50 years. That means effectively you're taking donors above 50 years, which in PDEC it's 25 microns, but I'm using only young donors, 20-year-old, 18-year-old, 15-year-old donors. Now we have created this bubble, make a knife entry into it, inject trypan blue, stain it, and you have your PDEC graft ready to inject. Now, one more thing advantage in PDEC, which for us there is no comparison between PDEC and the other procedures, is you can manipulate this tissue because the Duas layer gives you a splinting. Here you see we are doing an air pump filled PDEC in which air pump is continuously infusing air inside. And you can notice I've got fluid from the back with a trocar and from the front and anterior chamber like a trocar ACM. So both sides is working. Take the PDEC graft, take any injector, inject it inside. Now all I do is unroll it just like how you'll do DMEC. These are 25 micron grafts, inject the air. But look at the beauty of this procedure in PDEC is I can manipulate. In DMEC, it will tear. See the movement? I can move it wherever I want. Nothing will happen to that graft. That is one of the another reasons why we only do PDEX. We never do any other procedure. Apply the fibrin glue, seal everything down. The final question comes, how did this patient behave? That's the end of the result. So let's see how this patient behaved at the end of the day. This is the patient at the end, how he's looking. Now look 2 weeks post-op. Compare it to the pre-op picture. 1 month post-op, 2 months post-op. And now you can see the final picture, 3 months post-op, and end of the day, you'll see the 9-month post-op 2020 and compare it to the 6/6 vision compared to the pre-op. Thank you.